So my name's Stef Cormack. I'm not a medical doctor. I'm a paramedic by background. I've got a doctorate in the very fancy world of aviation, aerospace, and electrical engineering, human factors. I'm currently the head of patient safety at Sandwell Hospital Trusts. Oh, it's fun. And I'm going to talk to you about human factors in out of hospital cardiac arrest. And it's not all about the human. A lot is about the human, but there's a lot that's not about the human as well. So, as I said, I was a paramedic by trade. I got into this a long time ago. So I used to be a HEMS paramedic, critical care paramedic, and that's what got me interested in human factors. So it's all their fault. And there's me in action doing some of my research delivery. So for the last 10 years, I was teaching at university. And I did my PhD, and I've published and done stuff and taught students and stuff. So yeah, and now I'm currently focusing on trying to teach medical staff in a hospital about human factors, which is equally as fun. But tonight we are going to look at a little quick kind of summary of what human factors / ergonomics is. It's not just about humans, and it's not just about sitting at a desk and getting your eye level right and your chair and stuff and where you put your feet on the floor. Some of the wider issues associated with that. Then we're going to delve down a little bit more into non-technical skills, those social and cognitive and kind of personal skills that are so important when we're managing cardiac arrests. I'm going to touch on checklists. The wonderful world of checklists. Breaking bad news. Because it's all about communication. Communication is something that comes up again and again and again and again, and how we apply it all to an out-of-hospital cardiac arrest. So my PhD, in fancy terms, was I designed and evaluated a behavioural marker system, an observational assessment tool, for paramedics managing cardiac arrests. So it looks specifically at the environment we're used to working in, which is normally out of hospital, in someone's house, in a field, on the side of the street, in the dark, in the rain, or the unscheduled, unpredictable care. So human factors / ergonomics, because that's for the Americans. It's not just crew resource management. It's not just technical skills. It's so much more. And that's, going to geek out on you. And I know bake-off's on, but it's so much better if you record it and whiz through the adverts, so stay with me. So I've talked about this before, and I've melted people's brains with some of the human factors tools, and I'm not going to do that again because I was cruel. But human factors it's a holistic thing. So it's not just about you and how you interact with other people. We can throw animals in there like cats and dogs because they're unseen, and reptiles. But it's about the physical environment you work in. It's about those external factors like your guidelines, like your professional bodies, like your regulatory bodies, the scary ones. But it's also about the organisation you work in. And a good way to put it is systems engineering. And there's an amazing lady called Pascal Carrion. She's French, but she's lived in somewhere like Louisiana for ages. And she's got the most bizarre accent. She's brilliant. And she is an engineer by background, designed the SEEPS tool. So systems engineering, sort of a tool to look at the wider aspects of patient safety. And it's about how we integrate with everything else and the environment you're in, the tasks you're doing, the equipment, everything and anything that you can think about, that we try and make your life easier by making it easier for you to do your job. So it's a massive thing. And it does come down to a lot about design, because this is me. I started work for Sandwell Hospitals about 2 months ago. And on about the first week, I parked on the top of the car park in a multi-story. I couldn't get out the door. And I must have looked like an absolute muppet, because I was trying to do exactly this. I was trying to push a door that was a pull. And I thought, I'm going to have to walk down the ramp to get out. And then someone came and opened the door for me. So it's an excellent example of actually design. And it's the design of things that actually sometimes make your life really, really frustrating and annoying. And human factors engineers can help improve that. So I've totally stolen this from another great human factors person because it's just perfect. But human factors, it's not just about people. It's not all about eliminating error because we're human and we will make a mistake. We'll cock up. We just will. We can't help it. We get tired. We get hungry. We get hangry. And the way you see stuff and interpret stuff is different to everybody else. So fresh eyes is great on scene, especially in cardiac arrests. But sometimes you're so focused, you can't help but make an error. It's also about exposure. So exposure and team training, it's not just about that. That's a small piece of human factors. Not just about non-technical skills. It certainly isn't about crew resource management, which is just a small part of it, and non-technical skills fits in that. Definitely not trying to modify behaviour because you won't change people. It's trying to actually adapt things to work around people. It's not just about skills and simulation, and it definitely isn't just common sense, because if it was common sense, we'd all be fine. So it's about a whole system approach, and it's about trying to make it robust and resilient to things that we can't anticipate, we can't predict, especially in healthcare. And that's one of the biggest differences, because human factors sits in starting in aviation way back when they realized they needed oxygen, when they started getting up in balloons, and if you don't get enough oxygen you pass out and it crashes, all through the wars. And it's really developed because when an aircraft crashes, it makes the news. Lots of people get injured, lots of people die, big headlines. One person dies in healthcare, not so really headline news. So actually we've had to adapt. We've stolen stuff from aviation, we've stolen stuff from oil, rail, maritime, everywhere else, and we've tried to kind of fit it into the back of our ambulance and other areas of healthcare. It doesn't quite work. So it's only now that we're getting proper healthcare specialists, and part of that is the unpredictability and unscheduled care, because that's what we do. So it tries to modify the design to make it better to help people, and it can go from individual level all the way up to a complete organization. So from the top down and a bottom up approach. But it's about actually designing for us to use, not for us to try and make it work. And it looks at the different specialty areas, but also how we understand how our area works. So you can't just say, take a checklist and go, there's a pre-flight checklist. Well, I'll just adapt it and make it work for my cardiac arrest, because it won't quite work. And I'll tell you later the problems with checklists, which is many thanks to Prof. Ken Catchpole. So try and think about the whole system. We're just one person as part of a team managing a cardiac arrest. That's one ambulance, and there might be more of us, but part of a whole wider system, from a hub, from lots of hubs, from an whole ambulance service. It's got everything else going on. But then we should try and think wider. So we don't just think about the person, we think also about, well, what about the kit I'm using? What about the design of the defib, the ventilator? What about the kit I'm using and where I put it? What about the ambulance design? So there's lots to actually think about. And it's also about the technology we use, or the artifacts, all those variables we can't control. We've got people in our world. We can't, just put them in a room, put them somewhere else. And that all influences your tasks. And then we look at the physical side of it, psychological side of it, the emotive side of it. And actually, how does it work all together? So I think this is in Gary Rutherford's really cool book, From Human Factors for Pre-Hospital Care. It's called Human Factors Onion, which to me sounds like a complete steal from Research Onion, but that's a whole different thing. So thinking of the wider issues, there's quite a lot of literature if you go searching for it. And a lot of it is about stress, a lot of it is about resilience, a lot of it is about exposure, and the exposure to cardiac arrest for paramedics is pretty low. There's a lovely lady called Kylie Dyson in Australia, did her whole PhD and study on exposure rates to cardiac arrest. In Australia, they were like, it's not too dissimilar to here, 5 or 6 a year. And when I did my study, I did it on a smaller scale to try and get a snapshot. And it's comparable, maybe 6 to 8. But, I'm looking at quite a a large ambulance service. I looked at a couple of large ambulance services, urban and rural, but they all respond differently. One of the big pieces of work was by Sue Hignett from Loughborough University. If you're interested in studying, Loughborough's a great place to go. Edinburgh's doing a fantastic online course as well. But actually, back in, I think it's 2010, maybe earlier, they looked at the design of ambulances. And it's one thing that really bugs me, because ambulances, I mean, I joined the ambulance service in 1993. It's a fountain of youth. And they haven't changed. Nothing, not really changed. They're not really designed. And I went out to a conference in Winnipeg, in Canada. I get to go to all the best places. Winnipeg's fascinating. It's got the Museum of Human Rights. It's the most interesting museum you'll ever see, and probably the most depressing at the same time. And I went for a ride along, and it's just like here. It's just same sort of patients, same moans and groans, same issues A&E. But the design of the back of their ambulance was designed for you and the patient. It wasn't designed as a transport bus, dare I say bus. It was designed so you could actually treat your patient and do it safely. And I was like, this is great. Your suspension's awful, but actually this is really good. I could sit at the head end or at the side and everything's in reach. I can get everything and anything I need. And there was even like a little desk area you could pull out and put their essentially a laptop they use for EPRFs. So they could actually properly type and document stuff equally. You could store that away, and it's great. And Sue Hignett and the others there from Loughborough looked at the design of ambulances and made some really good recommendations, and nothing changed. The other really not, and this is true geekiness, I'm really sorry. There's a paper by Harari et al., and it's about where we put our bags in a cardiac arrest. And it's truly geeky because it's all about musculoskeletal injuries, and actually thinking about your practice. You come in, you dump your bags, you dump your monitor, and then I've done it loads of times. You're reaching, you're kneeling, you're reaching another patient. You've probably got your head between someone's legs at some point. At some point, somebody's straddling you. We think about moving the patient. There might not enough room to do the patient, move the patient, people to move the patient. We go on about 360-degree access. It's not always possible. So actually, we're putting our own bodies at risk because of the way the bags are designed, because of where we put them, because we're so focused on actually getting to the patient. And so actually that paper is really interesting. And I know you're all rushing out Google now and Googling it and going, oh, great. But what they did some simulations, and they gridded it and they looked at it and they did all kinds of stats, and they found the optimal area. And again, it's that same position. It's actually get myself a head end where I can do everything I need and where I can reach everything. And for anyone who works in sort of HEMS land or enhanced care, there's a lot of practice goes into actually positioning yourselves. So the weird stuff is, it is about the human, but it's about everything else that interacts with you. So from the positioning of your bags, the design of your bags, the design of your ambulance, actually how stressed are you? It affects your communication. There's a whole thing on patient safety, and actually understanding variability and everything else, and human-centered design is all the kind of stuff that should make it easy for us to do our job, but isn't always there. And then the wonderful Stephen Shorrock does just a great Twitter or X or what it's called now, lots of stuff on humanistic systems. And it's about trying to understand actually how we actually do our job. How do we do work as done? Natasha, I'm going to share the PowerPoint, and there'll be loads of stuff and loads of links on it, so you'll get it from CPDME, so don't worry. But it's about that work as done versus work as prescribed. So how we think and what it's written down in your SOP and your policy, which doesn't reflect because someone wrote it in office, has never been to your area of work, which is then work as imagined, which informs the policies and procedures. Then we've got that workers judge, dare I say it, the HCPC, the regulatory of that. That's why you have someone on the panel who's there to say, oh no, that's normal. That's quite normal to do that. That's standard. So that's that workers judge, because it always comes back to, but how's it done? And that's what's so important to try and understand. And that influences design of equipment, of ambulances, and then what you do. And then that influences your work as simulated, because we all like it to be real. I have to give a big up to Prof. Rona Flynn, because she examined me and she was lovely, and she had a cat. And I do like a cat. I haven't got cats anymore, just put that out there. Don't have any more, live on a busy road, and they all got cancer and died, but I do like cats. And she had a cat, it was great. So non-technical skills in healthcare is generally the cognitive, so your brain bit, your social, your communicating, how you teamwork, how you get on, and those personal resource skills, your emotional intelligence, your kind of how you put it all together, so your exposure and everything. So they help you do your technical skills, so your clinical skills, and that makes everything a little bit more safe and a bit more efficient. So if you're really interested and you want to look at a good book, Safety at the Sharp End is really good. It's very applicable to paramedics as well. And Rona's, she's done a lot. She's done a lot with Scottish Ambulance Service as well. She's really tried to understand it. She's a lovely, lovely lady, excellent lady as well. So what does the research say about cardiac arrest for us? Well, we're a bit unique. We are unique in the world of out of hospital care, because even though we should have quite a flat hierarchy, everyone's kind of paramedic level-ish, from students to sort of technicians to paramedics to even critical care paramedics. The kind of the skill set is very similar, which means you do get a mix of clinical competencies and team members, but it's more about the exposure and experience. There does seem to be a bit of a lack of understanding of what people can do and what people aren't comfortable doing. So it comes down to confidence. And we do have this thing about focusing on titles. That's generally in healthcare. If you're a doctor, well, you must know everything. Or actually, what are you a doctor in? Hand surgery. You're no good to me if I'm having a problem intubating. We're not brilliant at leading. We're certainly not brilliant at communication. Our incidents evolve. Things change. More people turn up. Family turn up. We might be in the road. We might not. We have to move the patient. Things change. And what we get is an unfamiliar ad hoc team. And that really doesn't help. That doesn't help the team dynamic, and it doesn't help understand who's confident and who's comfortable, who's familiar and doing what. And when I was doing my research, I did a lot of focus groups and a lot of listening and hours of transcription, which is worth it because it was gold dust. And someone said, I was focused on an airway and I got so focused, it was like I couldn't turn my ears on. And he said, I didn't hear a thing that was going on. Someone else said, I don't really know how to use the Parapack, so I just don't use it. Someone else was very much like, I just do CPR. I'm comfortable doing that, so I just do it. And I said, don't you get tired? And like, oh, I'm knackered. I'm really tired, but I'm not doing anything else because I know how to do CPR and I can do it well. So lots of stuff came out, and it was about that task focus, that overload, that bit where you just can't have the space to think. We're very focused on targets. We're very focused on, are we doing our 20 minutes yet? Oh, typical, they've gone into VF. Rather than thinking what's right for this patient. We're not brilliant with comms. We're not brilliant with verbal and non-verbal communication. And actually, we do get stressed. We do get tired. We can be very emotive. And I remember going to a lovely chap, gone home to die, and he was only in his 30s, and his wife called us. My crewmate said to me, you know, when you pull up a dress and you go, oh God, I've been here before. And she says, I think I brought this man home to die last night. And we went in, she was there with her daughter, and she said, I just want you to try. And I'm quite desensitized. I'm quite focused with the clinical tasks, and we kind of cracked on doing a very sensitive resuscitation because we knew he had come home to die. And we kind of went through all this kind of skills and explain what we were doing. And then she said, "He's gone, isn't he?" And we went, "I'm really sorry, but yeah." And I said, "Would you like us to put him back into bed?" She said, "Yes, please." So we put him back into bed. And I turn around, and my crewmate is in the corner of the room with the wife and the kid, and they're on a hug and they're all crying. I have to say, I didn't really know what to do. And probably because I've been so focused on the clinical side that actually, for me, that's my coping mechanism. But it was incredibly emotive because my crewmate had spoken to this poor patient and their family the night before. And that really played a part. So part of things are like debriefing, actually. And it was that kind of recognition of actually people will be out their comfort zones. It might be their first arrest. It might be their millionth arrest. They might not have done for ages. So actually, that really influences their decision making as well. And then we've got the environment and everything else. And as I saw someone put up bandwidth, and I'll talk about bandwidth in a bit, but it's having that cognitive space to actually think, what's going on, and can I make sense of it? And I'm going to come to that because that's another big finding from my PhD. So why do we cock it all up? The ad hoc unfamiliar team doesn't help. It really doesn't help because we're not mind readers, and we don't know what people know and don't know. We ask people to do something, and they might feel pressurized to do something, and then they don't really know how to do it. And we've all seen the reports where eye gels have gone in backwards or even in with cradles, and people just can't. You know, when you see something, you're like, that's not right, but I can't tell what's not right with it because my brain's full. And it's those eyes, it's that teamwork that really helps with that. The environment and the noise really doesn't help. And for us as out of hospital clinicians, we have to not just manage our scene and our patient, but bystanders, relatives, and other people as well. And it could be medical arrest, it could be traumatic arrest. So there's lots of things there that actually mean you've not just got your clinical tasks to do, you've got the whole thing to manage as well. That influences our task load, that increases the pressure, that means my stress goes up and goes on and on and on. Then my communication fails. I'm rubbish with names, and you start pointing, and someone thinks you're being arsey, and you're not. It's just you're trying to be sort of efficient, and it comes back, and they're going, "They were really abrupt," and you're like, "They weren't being abrupt. It's just they're really stressed, and they're trying to get through to you." And we don't get much information. We get there, and what tends to happen is you get focused on the patient, and then you've got a set algorithm to do, and you focus on doing that, and you focus on trying to think, should I start? Should I stop? Should I go? Have I got do not resuscitate? I just have limited information. And then it keeps changing. So because we're all target led rather than the patient, we get very focused on algorithms and what we think we need to do, and we miss out bits of information. And that's why we might make poor decisions, or in hindsight, you might kind of go, yeah, do you know what? If I did that again, or now I know what I know, I wouldn't have done it that way. And in fact, I thought I checked the drug. I didn't actually read it because someone just flashed it in front of my eyes, and I was trying to count CPR, and I was trying to do this, and I was trying to do that. And I got a student, and I was thinking about them, and I was thinking about what they need to get signed in the pad, and they were really stressed, and I was trying to manage them, and I just made a mistake. So it is very easy just to make a little slip. So when it comes to non-technical skills for cardiac arrest, in a way to try and make it a little bit more easy on the team, this is from in-hospital research by Fernandez Castello et al., who've done lots and lots of research, and there's also Hunziker et al., who've done lots and lots of research as well. But they're all in hospital. There's very little research for out-of-hospital cardiac arrest, which is fantastic because it's a massive gap. But what they look at, they get more time to brief. So in hospital, there is time to actually brief. The team can still be unfamiliar, but they probably will know each other. But the environment doesn't really change. The the kind of emergency teams who go to cardiac arrests will know each other, and they've got very set predefined roles. So actually this kind of wheelie thing with the planning, the leadership and the communication is kind of similar to out of hospital cardiac arrest, but the leadership is a key difference because we don't have that hierarchy where the doctor's in charge because they're the senior clinical person, because we might have 4 or 5 paramedics. I might be in a little kind of dream world there. There'll be a mix of students, paramedics, techs, ECAs, other things. So when I did my research, and I was under engineering, I apologise, it's an input, process, output model. I looked at the individual factors for people, team factors for the crew, the environment. So all these things that affect how we work, how we make our decisions. Because I was trying to think, well, what are the key social and cognitive kind of skills that paramedics need to help them manage a cardiac arrest really well? I understand why they're not going so well and why mistakes get made. So how can I kind of try and reduce that error? It's a posh flow chart. Don't just call it a flow chart. Where are the engineers in the world? They go mad. It's a flow chart, I know. It's fancy. So I was looking at all these bits and bobs, and I came out, I was looking at these non-technical skills, and leadership still came up. I was like, okay. And then situation assessment, which is slightly different from situation awareness, which I explain, communication all the time, teamwork and team coordination. And I did all this, and then I followed up with, I did a mixed method study. It was huge. It was a bit of a monster. So there's a lot quantitative, a lot qualitative. Just pick qualitative. It's much nicer. But it was the qualitative stuff that helped me really narrow it down. And then there's a human element, because we're human. And as you mentioned, that bandwidth, that cognitive load, how much can you process? And your brain, it's a little bit like a computer in a way. It has working memory and long-term memory. So it's these different storage banks, and it's that mixture of basically information you've learnt that you might have learnt from a CPD session, a lecture, a book, presentations, those kind of thing. So that's kind of ingrained in there. That's the learnt knowledge. But then we've got the working memory, which is you kind of experience, your exposure, that practical application of what you've learnt. And you mix that up with real life. And that's that work has done work with the work as prescribed and the work as simulated and stuff. So we get certain information from everything we do, and we kind of store it. And when we start to actually go and do stuff and make decisions, we start to process the information and make sense of it. And sometimes you have to dip back into your long-term memory. Working memory is quick, easy, dirty. And long-term, I've got to stop and pause, and I've kind of got to go through a filing cabinet, and I've got to find it, and I've got to remember it, and I've got to apply it to what I'm doing. So it takes a little bit more cognitive processing. But that needs to help you interpret the scene that you're seeing. And we're really good at getting distracted. So we get challenged for our attention. So you could be saying, hang on, I've just got to concentrate. I've got to think what this is. And then someone else is saying, can you help me do this? I need to do that. Can you do this? Can you count CPR? What round are we on? What cycle are you on? Are we shocking? How many shocks have we gone? And you go, I don't know. I was trying to figure out something else. We've got our senses as well. I was terrible when I was on an ambulance because I get really distracted by cats and dogs. And also, I was absolutely useless with babies and children because they're just terrifying and they're so small. And I would just kind of think, I don't know what to do with this, and want to offload it. So all this kind of load, we're trying to balance all the time. And there's some stuff we'll just know. Some stuff's just in my working mind and I can do it. But actually, if I've got to go back to that intrinsic stuff, that extraneous stuff, and actually dig down and think, oh God, it's been ages since I've done a cardiac arrest, then that takes time. And it's a bit like when we're driving a car, because you can't do two things at once. Believe me, You can't. I know the argument. I know there's some probably male people out there go, yeah, you can do two things at once. Because I've had this discussion with resuscitation officers. It depends on what you're trying to do with your brain. So if you're using different parts of your brain for the two different tasks, yes, you can do two things at once. Like I can drink a drink and read a book because they're very different. But if I'm trying to drive a car and use my mobile phone, I'm using the same bits of my brain and the same processing pathways. And so one of them will have to fail. Concentration will drop out on one, and you either crash your car or you send a weird, inappropriate message to someone else. So it does depend on your human information processing pathways and whether you're trying to do something in sequence, one after the other, or simultaneously. So we can do things to make it easier for ourselves. And I know the literature around mechanical CPR says it doesn't make any difference to survival. And yes, okay, it was a big RCT. And yes, it was a decent design. But actually, there's so many variables. And actually, the outcomes were focused on really not. The outcomes had so many influences that actually you could argue, well, these patients were always going to die. It doesn't matter. But it made a hell of a difference to us as a crew because I didn't get as tired. I could do CPR when we're moving a patient, and it made it so much safer when I was in the back of a moving ambulance for me. And this is the thing, this is the human factors element of actually, if you use things like mechanical devices for CPR and ventilation, it can reduce your cognitive load, so it can increase your bandwidth. It can actually mean you don't need as many people, which can be a good thing. There does seem to be an optimal kind of number of about 4 to 5 makes it easy because actually you can allocate clear tasks and everything anymore, and it gets messy. And people all want to do the cool stuff like IOs and airways, and we can't all do that. But you need to know how to use equipment. And if you're not used to it, you're not familiar, then actually it just adds to your stress, adds to your cognitive load, which makes it worse. And don't forget to monitor them. Don't forget to keep checking that they're actually working. So it can free up people to use, dare I say, a checklist, or to do other things, speak to family, go get more information. So it's a really interesting thing, actually, if we can offload, and it might be offloading tasks to other people, so that you can be as free as possible to make sense of the situation, to interpret the rhythms, the algorithms, the extra information that's coming in, then that's a really, really helpful thing, particularly in out-of-hospital cardiac arrest. And if you ever heard of the Stroop test, it's not waffles. And in the presentation, in the comments, there's a little link. It's a fantastic test to take. That's hard to say. Because, again, it's about processing information and what you see and linking it to your mouth. It's really cool, but I don't really have time to do it with you here. And it's quite interactive, and it's not as fun if it's online, if I'm honest. Which brings me to cognitive freeze. So the Yerkes-Dodson law, the optimal stress. And see, this is me now have to get my long-term memory because I can't remember the man's name who does the performing under pressure stuff. It's someone's going to put it in the chat, I know they will. The optimal stress. So that underload versus overload. When we're too stressed, we can't process information properly. When we're underloaded, we don't have the stimulus to actually have that little boost of adrenaline. So too much stress and you're going to freeze your mind, but too little of it, and we're not kind of stimulated enough. So you can get that Stephen Hearns. There you go. Thank you, Rebecca. You can get the tunnel vision. You can get the tiredness. You can get that I can't turn my ears on. I can't actually listen or hear what you're saying because I'm really busy. And I was involved in an incident in an aircraft where there's a little bit of pilot, poor flying, and we kind of dropped a bit, quite a lot. And I got completely, well, I was thinking we're going to crash and die, thinking that a lot. But what happened was I couldn't hear anything. I just stopped hearing. I don't remember hearing any of the warning signs, but I could see them all. I could see everything was pinging up on the screen, going crazy. And when I think back, I thought, I couldn't remember my call sign for control. So I reverted to an old one. I didn't really know where I was, and I stopped listening. I stopped hearing anything, and I forgot about the doctor in the back. I was quite task focused and overloaded. And it wasn't until we successfully landed that I turned around and I went, this poor doctor. So the stress level really influenced how I performed. And I have to say, I didn't think I performed very well. But brings me on to overconfidence, because this is a killer. It's actually the Kruger-Dunning. If we look at the students' works, it's for a PhD, but supervisor stole it and went Dunning-Kruger. So it's about this confidence and competence thing. It's about, so lots of things I found in my research were to do with confidence, underconfidence a lot. But coming back to those non-technical skills for leadership really wasn't a term that was light. It wasn't a good phrase. People associated the phrase leadership with overconfidence bordering arrogance. And they said they're really bossy and they just shout at you, but they want to do all the clinical tasks themselves, and they don't really know what's going on. They don't really know the algorithm. They're not actually that good. And this came up again and again and again. It wasn't just in sort of one trust that I looked at, it was in other trusts that I looked at as well. And we all go through stages. And it's fascinating because teaching undergrad students for the past 10 years, I've seen this a lot. And it goes through the student years of, so that first year of I don't know anything and I'm absolutely pooing my pants, to the second year we're like, yeah, look at me, I know what I'm doing, I'm really good, I'm brilliant. And then to the third year of I have no idea and I'm really worried now. And then you get near qualified and it starts to pick up again, and then you'll have an incident where it just completely bombs out, and then you get into that nice plateau. But this is very much related to that exposure. So if you're not getting much exposure to out of hospital cardiac arrests, then the only thing you can do to try and improve your own kind of familiarity, which in turn increases your confidence and your non-technical skills, is practicing simulation. But we all know that simulation ain't that great. We've all seen it in training rooms, we've all seen it at university, and it's not real. And you always get that, I wouldn't do this in real life, I wouldn't do it on the road. And you go, really? Because before I left, we did some pretty decent simulation. We tried to make it real. I mean, I gave birth 6 times in a day, making it real for our students. There's a photo somewhere on Twitter. That is not a glamorous look for me. But it just gave them those other things to think about. So it kind of took the focus away from clinical tasks to try and get them to increase their team working and communication, and actually that team coordination, to actually increase their confidence. So actually we get a nice plateau. So that you're always kind of thinking, I don't know everything, but I know enough to be safe. And that's what we really, really want. So which ones do apply to cardiac arrest teams? And the picture in this is spot on, because this was in a simulated kitchen. And we ran this hundreds of times. And every time, and these are experienced, these are not sort of your kind of direct entry students, these are, dare I say, experienced techs. No one moves the patient. This was a tiny, tiny kitchen. It's too tight. I spent most of the time sat on the worktop watching, because it's a very tight kitchen. It's meant to be tight. But the amount of people who then tried to manage the airway tucked in the corner, who didn't make it easy for themselves and actually made it difficult to reach kit, just like the Harari paper, then it's optimizing what you've got to make it easy for yourself. So team coordination came up, and it was really because of that fluidity of teams, of pre-hospital teams, because the first person there may not necessarily be the leader. They may not want to stay the leader. They might not be comfortable. But also, if you're the only paramedic, you're going to have to be hands-on doing clinical skills. And to be honest, all the evidence suggests, especially in hospital literature, if you want to be leading, if you want to coordinate an arrest, then actually you've got to be hands-off. So actually, there's a very fluid moment between the leadership and followership. And followership is really, really important, because it's about being part of that team, accepting tasks, chipping in with your information, and sort of saying, actually, what do I need to do to help us get to here? Who's that best person to actually lead this? I'm trying to see the comments because there's a really good thing there about handing over the baton, but it's verbalizing that, and it's recognizing your own bandwidth, and it's hopefully stuff like this that gets people thinking about it and not being afraid to say, no, I'm full, I need someone else to do this. Because also the 360-degree access we can't always have. We know that people collapse in the most awkward places, and you haven't always got enough people or physical kind of strength to move them. So it's about trying to optimize your access, and that comes back to that leadership followership, and actually that handing over that baton, if you like, to say, do you know what, I just want to just be part of the team. I don't want to manage this cardiac arrest, and actually not just going with the person who's got the loudest voice. Does it need to be better? If it's comparable as a minimum, then surely this frees you up to look at other. See, this is me communication. Oh, it's gone. This is well moving about, isn't it? Talking about Lucas. There you go. That's because I haven't looked at the other comments. It depends. I know in some trusts they use Lucas to reduce their responses because actually it's a pair of hands that never gets tired. So actually it does free you up to do other tasks. So it frees you up to do other clinical tasks, go to speak to people. So that's really helpful. And that then flows with that leadership followership. Decision making is linked to situational awareness. Now, situational awareness is a 3 kind of tiered approach, and Mika Ensley has written so much on this, it's untrue. So she came up with the idea back in 95 that actually it's about getting information, which we know as paramedics out of hospital, it's limited, it's varied, and we don't always get it in a timely manner. So it's gathering information, it's making sense of it. So it's the processing of that information. So it's making sense of, I've not seen that rhythm before, what the hell is that? To, we haven't got the information about do not resuscitate, so we're going to start. So this influences decisions. The third stage is anticipation. And the thing I found in the research was we're not brilliant at anticipating, and that's possibly because we use algorithms. We're on a set pathway regardless, and we've got certain decisions that actually influence our decision making. So our anticipation was really, really limited. So I took it back a step and called it situation assessment, which was a big talking point with Prof. Flynn, because she's also done a lot of work on this. And it was basically from her work that I kind of developed it. And I said, it's because our decisions are really influenced by our clinical guidelines, our clinical algorithms, our employers' policies. And actually, we are kind of limited in a way with what we decide. And therefore, we can have an A plan, a B plan, but we don't really anticipate. So decision making is getting a judgment, but also it's for us, it's following algorithms. So using things like a Lucas device, like mechanical CPR, it does free you up to try and get more information to make sense and hopefully take to the next stage of anticipating this is going to happen, this isn't going to happen, because then we've got patients, another variable. And finally, communication. Communication is different to every single other healthcare behavioural marker because communication forms a thread in all those other behavioural markers, and surgery's had them for ages, aesthetics has had behavioural markers, ants is a big thing. But for us, it was such a massive standout thing. It got its own skill because this wasn't just about us sharing information with each other. It was the public, it was different medical care. So you've almost got 3 different languages. We've got ambulance speak, we've got layperson speak, and then we've got hospital speak as well. So it's actually very adaptive, very important, but it's also that verbal and non-verbal side of communication. And again, it goes back to that ability to actively listen. And these 4 non-technical skills really influence your stress levels. So if you have a well-oiled, well-practiced, familiar team, it goes so much more smoothly. If you know your people in your team, if you know names, that can really, 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 really help. And actually, if you Rebecca's very lucky to have a Lucas on every ambulance in Ireland. It's not that we're jealous. It's because actually the way you work and the rural nature and the distances you travel, actually, it means you probably get 3 people. But it's a lot easier to manage 3 people, even if you're unfamiliar, than say 8. And most of the cases I've looked at, because I used to work at the HCPC as well, where things have gone horribly wrong, there's been a lot of people involved. So yeah, and then it goes to safety. So we're thinking about the wider system issues again. So, why won't you move? There we go. So I've talked about that, and it is about that situation assessment of actually, what do I know? What information have I got? How much can I make sense of it? But it's that wider team situation assessment as well. So it's about actually gathering information from everybody else and not staying quiet, which again goes back to your teamwork and decision making and communication. So they're all very linked. And I'm looking at the time because I'm thinking Bake Off's on. But poor teamwork really, really does influence our decision making. And all these things that we're already kind of associated with error and slips and mistakes, they all influence our decision making as well. And the exposure. So where we don't have much exposure to managing cardiac arrest, we'll probably make poorer decisions than whether we've got a team who's very exposed and used to it, as such as enhanced care teams or HEMS teams, because it's kind of like the bread and butter. And it's the same with major trauma. And then the environment really has an influence on your decision making, because you might have misheard something. You might have had a piece of information that you weren't aware of because someone else had it and couldn't get to you. So there's a lot of issues there. But the main influence on decision making is really that autocratic leader, that leadership style of, I'm leading it and no one's going to tell me that I'm not, because I'm in charge. And I hate to say it, but it does seem to go a little bit hand in hand with how much stuff's on your shoulders. Clinically, all the same clinical level. It's a very flat hierarchy. But that does come with some people, when you've got more gold on your shoulders, it influences your behaviour and decision making, and it really disrupts the team. I'm glad to see some thumbs up, and probably people going, yeah, I've been there. So what can we do? We can do active listening. So can you listen? Do you want to listen? Do you need someone just shouting at you, or are they actually being helpful? What do you mean? Because actually it can get lost in translation. So being really clear, using names is so much better, but we don't always know names, or I can't remember names. I'm really bad. I can see faces. Names terrible. What do I actually need to say back to you that so you know that I've understood it? And this is this closed loop communication style, and it's really hard in a pressurized situation, and it's changing something. It's I know they've, in the answers they're teaching the I'm uncomfortable, and now I'm concerned, and now I think it's dangerous. But from a practical kind of application to it, it's about actually practically changing something. So changing the tone of your voice, the volume of your voice. You could use language. I don't mean like swear at somebody. Don't say "oi, chuffer." It's actually changing what you're saying. So maybe they don't understand, but they just block it out. But it's names. And when I say touch, I don't mean like slap him across the face. Give him a little tap on the shoulder, something to get the attention. Because like my participant said, it's like I couldn't turn my ears on. And I've done this with a professor of anesthesiology. He was trying to intubate, and patient's desaturating, and he wasn't listening to a word I was saying. I changed my tone, I changed my volume, I used his name, and then I gave him a really good shove because he was a lot bigger than me. And I thought he was going to kill me, actually. His face when he looked at me, I was like, oh. So it worked because his story was doing, we ventilated and we changed operator, and I intubated and got it in first time. And I wasn't smug at all. We didn't do smug face. And he said, we'll have a discussion about this when we get back to base. And I thought he was going to go nuts because he was well into his knife fighting. And he said, no, I needed that. He said, I didn't hear you. He said, I was completely focused on what I was doing. And he said, I really, really just needed that. And he said, it was well managed. And I think looking back, if I'd gone, Pete, I'm really uncomfortable, or Pete, I think it's dangerous now. It wouldn't have worked. It wouldn't have done anything. What actually worked was, oi, Pete, shove, desatting, stop. So yeah, I know I could do that with him because it's familiar, but you wouldn't have to have a debrief after and say, I wasn't being rude, I wasn't being funny, but it was getting to a critical point. So it's practical application. Whole slide on team coordination and leadership and followership and staying hands off where you can. Appreciate you can't always. So actually it's doing the thing that means you're the least amount hands on possible. So probably shoving in Elijah and just doing vent, because that's one thing you can do twice. You can do two things at once. You can vent, give everyone a BVM, and everyone just gently squeeze away, have a conversation, make a cup of tea, do something else. So that's one good thing you can do. But it's about actually having that trust. It's about thinking, yeah, I feel like I can speak up here. I feel comfortable. So it's being assertive but not rude. It's being respectful. It's listening. It's putting your point of view across as well, and not doing it in some kind of arsey way where you just end up pissing everyone off. So it's very difficult. And it is about, as Gareth says, about framing information. So saying, okay, we've got a decision to make here, everybody. Oh, Roger, you see Pete. Yeah. I was worried he's going to stab me. But it's actually about communicating as well. If an information that you've got that maybe people haven't got, or maybe they haven't recognized it or heard it. So actually it's that fine balance, and roles will change. We will change because there's not enough of us do a cardiac arrest to do every role. So you might be doing CPR, but then you might be doing something else. Then you might be going chatting to a family. So it's about accepting that actually I'm not going to do all the stuff, but we need to work together to actually make us work as an efficient team. Which brings us to efficient teams. That's very good, isn't it? And again, it's that cross-monitoring. It's that double-checking. It's that going back and forth. It's about actually using the closed loop. And I'm hoping the next slide is checklists. Isn't that a beautiful link? So checklists are really common in aviation. And there's different types. The World Health Organization uses it for surgery, and surgery don't use them because they don't see the benefit of them. So there's no buy-in, and that's one of the things with checklists. There's either the read and do, which is like a recipe, you read it and you do it, bake off, or you get a challenge and response, and that's probably more useful in cardiac arrest management because it's more of a memory aid. Have we done that? And I'm asking the team now, so they need to be simple. And Ken Catchbowl, I think it's Simon Russ, did the problem with checklists, and they were kind of highlighting you can't just take the idea of checklist and shove it into healthcare because it won't work. It has to be designed with the people who use it for the task at hand. You've got to have that buy-in, but also it's got to be designed for use. So it's got to be usable. It's got to be tested, but also people need to be trained and educated in them, and you've got to be able to find them. So one trust that I did some work for had a checklist, but it's paper, and one of the feedback was, I can never find it. And if I could find it, it's too jumbled. It doesn't make sense, so I just don't use it. And that's the thing with checklists. They can be really helpful, but actually it depends on the hierarchy of roles, because someone might say, oh, we're not doing that, but actually other people want to use it. So they can be very, very useful if they're designed well and with the user in mind, and actually in the process of designing it. And actually, if you're trained in it and you can access it, they can be really helpful if you've got somebody who can be hands-off enough to use it. So checklists are good, but they do have their flaws. And I've got some examples. This is an American EMS, and it's not actually a checklist, it's just a list. I don't really know what it was. Then we've got, you're seeing HEMS enhanced care teams use pre-RSI checklist a lot. And they're that safety netting of actually, have we got all our monitoring? The one with this, I look at monitoring, it says according to SOP. I don't know, because I can't access the SOP and I can't remember it, and I'm very busy, and what is that? So actually, it needs to be specific to the task at hand. and then Greater Sydney Hems. And actually, this is, you can see here, this is a challenge response. So this is that memory aid, which you might think, yeah, I know this, I don't need to do this. But actually, it's to make sure we don't miss anything. And it then verbalizes to everybody else, and it forms part of almost a little brief. And then finally, the London one. The problem with this is there's 3 checklists on one piece of paper. And actually, it might not be as effective in use as a more specifically designed one, because this is, in London, I know they've gone to the automated defib, so it's AED mode and a metronome. And I did I did a lot of scenarios where I use metronomes. People don't hear them. Some people love them. A lot of people just simply don't hear them. And then you say, "Did you not hear the metronome?" They go, "What?" And they go, "What's that? What's that ticking?" So there's certain things that actually it's about the application. So how can we improve? Well, regular training, regular good realistic simulation, but you need buy-in. You need to have the whole team that they actually understand what really, so the shared mental model. Actually, what's the aim of this research? Are we on the same page? Leadership is useful, but it goes hand in hand with followership, and it just because someone's there first doesn't mean they're going to lead. When I say get familiar, I don't mean in the way that Andy said be social and share your photos in the bath. It's about learning people's names, and actually sometimes your partner has no rhythm. It's about understanding when was their last arrest? Have they been to arrest? What can they do? What are they comfortable in doing? And it's those things. Yeah, if you've got no rhythm and metronome, it's useless clapping off the beat. Oh, you don't have them in scars? Well, that's unusual. Yeah, so it's about yeah, it's knowing your team. So the familiar teams are so much better. But if you're not, it's actually saying, "What's your name again? What's your name again?" In COVID, even though we were full of PPE, it worked quite. People wrote on them, so you knew clinical grade, you knew a name, and actually it did help communication. The metronome's fault, yeah. Be diplomatic. You might have to bite your tongue. You might have to listen. Share your decisions. Offload with each other. Explain yourselves. And recap. Go through it. Use that kind of, okay, we're now going to do this. Use that designed understanding so everyone knows what we're kind of doing. And if you're going to use checklists, please make sure it's designed and validated and usable. Oh, roll 2. The other main thing you can do is recognize your own bias. And there's a multitude of different types of bias, but actually anchoring bias is really prevalent in pre-hospital care because it's just fixing on that first information, especially in cardiac arrest, of just fixing on they're in cardiac arrest. The bandwagon effect. Speak up. Don't just go with the flow. If you're not comfortable, please speak out. Confirmation bias. Don't just go again with what someone says. Be prepared to challenge. Be prepared to speak up. Don't stick your head in the sand. And actually use the information that you get. Keep reviewing it. Don't stop gathering. Situation assessment and awareness is very much about continual information gathering and making sense of it. So actually it's about how we perceive things as well, because sometimes it's hard to recognize new stuff when you're so in, your head's in and you've been with that patient sometimes it needs fresh eyes to turn up and sort of go, that's not right because your eye gel's backwards. So it's things like that. So planning, if you can plan, that'd be lovely. And it might be a very kind of rapid assignment of roles at the start. It might be just sharing your own mental model with the rest of the team, but that links to that decision making and actually what do you know, because other people might know different things. Try and flatten that hierarchy, ignore the pips, try and leave the egos out, and try and actually breathe. It's really important actually just to try and take some deep rest sometimes, and sometimes you have to just reset yourself and just think, hang on, I'll go back to A. Okay, I don't know what I'm doing, I'll go back to ABCs. But yes, we need to prioritize things. We need to actually recognize they're in cardiac arrest. Sometimes that doesn't happen. And also recognize that we do need assistance, call for help. I called for help once when I was on ambulance from an officer and he came back with an entire fire engine. It was very useful, actually. I didn't have to carry anything. But we need to actually look at the literature and say, what actually does improve survival? Well, bystanders recognising the arrest, bystander CPR, early defib. So it's that continuation of care, but it's that sometimes we might not get the information we need to make a decision until 20 minutes in. So again, it's continually gathering that and actually understanding what are we doing for this patient, what are we trying to do for this patient, what is the best option for them. If you can secure your airway, lovely. If you can access, lovely. But keep reviewing yourself and your patient and the safety throughout, because sometimes we make difficult decisions because we are not in a controlled environment. Sometimes we have to make difficult decisions and say, this is not safe for us. We're going to have to withdraw. So keep reviewing. Has anything changed? What have we done? Where are we on the algorithms? Anybody know what cycle we're on? How many shocks we've had? Well, we'll do it by counting the drugs. Who is the best person to actually do what we need to do? And actually, do we need any more help? And if we do, ask early. Might not get it, but at least you can ask and you can keep asking. And sometimes fresh eyes are really useful in viewing it afresh, getting more information, listening to a handover and update, and making sense of it because you're not so in. Can you listen? Actually, are you doing something where you can actually listen? Or are you going to have to say, I'm sorry, I can't listen at the moment. I'm doing something. I'm concentrating. Not being rude, but leave me alone. And obviously change something when you're speaking to someone if they don't look like they're listening. Feedback and forwards. So it's really important to actually debrief teams and to say, did we do kind of the best we thought we could, or could we improve? It's more about learning than actually blaming. But also, there are devices now for compression feedback. Obviously, they cost, so some trusts don't buy them, but the little pucks you can get with Cesar, they're really good for your CPR quality if you haven't got a mechanical device, but they take so much concentration. And if you do really effective CPR for 2 minutes, it's really tiring. I mean, it's really tiring. And then if someone's trying to talk to you, you can't do that. You can't actually monitor how good your CPR is. And it's really easy to stand there and watch someone going, "Oh, you're going too fast. Your CPR's rubbish." Yeah, well, you do it, and I'll talk to you and put you off. So actually, debriefs always very good, and keeping up with as realistic simulation as you can. If you can keep practicing with lots of people you don't know, it makes talking to strangers easier. And that sounds something like from a public information film that you shouldn't do. But it's about learning to work with people you've probably not met before, which, let's be honest now, with this kind of hub and spoke thing, happens a lot. Get to know your crewmate professionally, that is. Finally, and I will let you go because there's cake to eat, quite frankly. I've got 6 French fancies waiting downstairs. Breaking bad news and involving bystanders. This is a critical bit of your information gathering. So the literature says actually involving the family can actually really helpful and doesn't really interfere that much with us, and it can help with us getting information and actually can give them certain tasks to do. But we've all been there. We all know what people are like, and we know that some people could be helpful, some could be very unhelpful. So you need to give them a task far away. But it can also actually increase the stress of the team doing the arrest, and it can make it more emotive. People also say there's a physical burden as well, and actually, when there's been bystander interviews and literature, people are really worried about harming people. They don't have that same knowledge and understanding that we do of can't get any worse, they're already dead. But they're just really worried. They're worried about touching a stranger. They're worried about breaking ribs, because I think we've all been there. We've cracked a rib and you feel it and you kind of go, oh, carry on. But actually, across the globe, it's the same everywhere. And people will not do CPR on women because they're frightened of getting boobs out and also of being accused of assault. So actually, if you're female, have a cardiac arrest in a casino in Las Vegas because that's got the best survival rate in the world. There's defibs everywhere and everybody's training CPR. The other thing is, we're not very comfortable with family watching us. We don't really like what people watching what we do, even though they do watch what we do all the time, and they're most likely filming it. And then we've got TV. It's a whole other topic. But it is sensitive and it is challenging. And actually, people who are involved in CPR actually find after they need to be debriefed as well, because actually they kind of get left wondering, was I any good? Did I help? Did I make it any worse? And actually, for paramedics and ambulance staff, we don't have enough education in breaking bad news. We don't get enough support in it, full stop. And actually, education in this is really common from medical students, and maybe we should be adopting it. And some of the ways I had a look, actually, there's some models out there, such as spikes, A, B, C, D, E. That might confuse us because that's something completely different. And breaks, which is actually, again, preparing people to put them in the right frame of mind, the right setting, and actually that they understand what you're trying to explain to them and how much do they know. They're the right person to be telling. And communicate, how you communicate, that's really important. And my mum dropped down very suddenly, dead. And my poor husband, I sent my husband because I was at work, and he rang me up and he says, she's gone. I was like, gone where? On holiday? He went, no, she's dead. And I was like, you said she'd gone. And I'm a paramedic. I should have known. I kind of knew. But the choice of language as well, it's really bad. So actually, it's about having that empathy, but also using language that conveys the correct meaning of what you want. And it's about setting them up as well for that. Yeah, you can't spend your bandwidth counting. God, it's hard work counting. Oh, you work in St. Helena, British Overseas Terrier, cardiac arrest, limited conditions. Too many cooks for the broth. But so you're there, so you get stuck with having to do the clinical work, which is then very hard to manage the arrest. And then actually you're trying to improve your public education and defibs. Yeah, and that's the thing. It's about that. Do you remember I said at the start, the systems kind of thing, that more holistic thing? Actually, with cardiac arrest, it's about going that wider step out and teaching the community CPR and myth busting and saying it's okay to do this, it's okay to do that. If we ask you to help, if you're comfortable, please help. If you're not, it's fine as well. So there's a lot going on with cardiac arrest. Human factors can help. The other thing I mentioned before was about emotional intelligence, and it's about actually just reading people. We can be quite good at it. We can be poor at it. You can learn it. And it's tough because working HEMS, there's always a lot of it footage and photos of me, and my face is just, there's a great photo of me, and I look like I'm a zombie, actually, I'm honest, because I'm concentrating. And I don't look very approachable. I look like a complete moron, actually. But it's because I was really concentrating. It's my concentrating face. That and the tongue comes out. So recognizing the kind of, again, the non-verbal, the body language is also important in your kind of emotional intelligence, but also your self-awareness links back to the confidence, links back to the kind of your stress load and everything as well. And it's about, again, it links with communication. There are ways to improve it, and you can do it, but essentially it's trying to put yourself in somebody else's shoes and see it from their point of view, which is not as easy as it sounds. If you get it wrong, say sorry. Debrief, talk to each other, get familiar. So, huge amount of information to take in. Human factors ergonomics is huge. We do tend to focus on particular things like non-technical skills in healthcare, but we could make it so much more, especially when we break it into areas of healthcare and then clinical areas and then clinical tasks. It's not just non-technical skills. There's a lot of other stuff in there as well, but that's kind of the easiest thing for us to adopt and actually practically use. You can recognize and manage your own task load, your own cognitive load, and your own bias. Some of the most important non-technical skills, probably communication and situation assessment, that information gathering and making sense, because that influences decisions. Leadership and followership go hand in hand, and they are very fluid in out of hospital context. But a poor design and the culture of where you work can really make things work, and that's an entirely different topic. So, brings me to the end. Told you I like cats.